Thank you very much for your patience. Good afternoon. I know this is a post-lunch slumber, so I'm going to try and give you some of my thoughts on this topic, and I implore you not to shoot the messenger. I'm a recovering MIGS addict. MIGS really works well especially when there is no glaucoma. I truly wish all MIGS would work. Except for canal surgery, everything else is trying to do a better trabeculectomy, basically creating a better bleb. I'm trying to get away from becoming a blebologist, and the MIGS surgeries are driving me back towards becoming a blebologist. Why is trabeculectomy still the surgery of choice in moderate to advanced glaucoma and worldwide? And cataract surgery, remember, is the best glaucoma surgery there is for the vision improvement, the pressure drop, and the least amount of complications. Why did MIGS evolve? Post-op care is not adequately reimbursed by US insurance. There is unpredictability in post-op and outcome. Believing that majority of the resistance in the outflow pathway resides in the trabecular meshwork. Yes, these were based on the experiments done by Morton Grant. And he had implored everyone that it needs to be repeated because he had done it only in less than 5 eyes with a regular microscope. Also, with glaucoma surgery, you get poorer visual outcomes, and the patient says, "You did glaucoma surgery, but I can't see any better." One must remember that aqueous causes subconjunctival fibrosis. Is because of that we are needling after Zen. It is not the conjunctival handling, because if the Zen is being done ab interno, there is no conjunctival handling, but there is still tremendous fibrosis. How much more predictable has Zen allowed a trabeculectomy to become? Are we such poor trab flap creators that we cannot create a flap enough to control hypotony? So now we are deciding to put the Zen ab externo. Putting in a PreserFlow. Material is SIBS. Does it matter? It's not the material that matters. The material prevents fibrosis, but it's not the material that causes the fibrosis. It's the aqueous that it is shunting that causes the fibrosis. Its strength is that it pushes the bleb posterior to the limbus, but it still suffers from the fact that there is an inciting element that is aqueous. But needlings can become more difficult because the bleb is now further posterior. The Horizon study that you already heard today, although the primary goal for MIGS surgeons is often to reduce medication burden, mean pressure reduction of about 2, the mean number of reduction in medications is about 0.4 at 2 years. MIGS can reduce the need for secondary glaucoma surgeries by about 1.8 to 2.5 over cataract surgery alone. I want to point out the small percentages that you are seeing on this slide. And as Professor Kaveh Mansouri has published in this paper, The Current Opinion in Ophthalmology in 2024, while traditional surgeries offer robust IOP reduction, MIGS offer better safety profiles and fewer complications, more predictable refractive results. While MIGS have demonstrated promise in decreasing reliance on medicine, the quality of the evidence varies among the studies. There is a pressing need for additional high-quality, independently funded comparative studies to evaluate MIGS, efficacy, safety, and cost-effectiveness. And I'll come to that in my second last slide once again. Combining MIGS with phaco in open-angle glaucoma, a meta-analysis. This was published in 2024. Based on the current peer-reviewed articles, there is evidence when compared to phaco alone, combined MIGS and phaco is beneficial for POAG and does not increase the incidence of vision-threatening events. The key limitations is the heterogeneities in the protocol design and the limited number of high-quality studies with long-term follow-up. This is again another study from 2024. Adding a MIGS procedure to cataract surgery provided an additional 1.6 to 2.3 millimeters of mercury reduction in subjects with mild to moderate glaucoma at 2 years. The cataract surgery alone provided 5.4 to 7.6 millimeters of mercury reduction. This is a statement by the American Academy of Ophthalmology. In other words, adding a MIGS procedure provided only 3.8 to 8.9% IOP reduction over cataract surgery alone, which provided 21 to 28% reduction. One may approximate that cataract surgery alone has the potential to possibly eliminate 0.8 to 1 glaucoma medication, and that adding MIGS may have a mean reduction of medications by 0.4. That same article, it is important to highlight that all clinical trials on MIGS procedures were industry-sponsored and then thus subject to potential industry sponsorship bias. In addition, nearly all had first or corresponding authors who had financial interests in those specific companies. On multiple occasions, the authors, investigators had stock options or were owners of the company, consultants, or direct company employees. Are these procedures as benign as they are supposed to be? Well, let's look at some ocular complications within 90 days of the index procedure, XEN compared to goniotomy and canaloplasty. Look at the endophthalmitis, 6 in XEN, 8 in goniotomy and canaloplasty. Malignant glaucoma, 5 in goniotomy and canaloplasty. Vitreous hemorrhage, 11 and 69. That's pretty surprising. And this is from the IRIS database. This was another study that came and went and nobody paid any attention to it. It is the endophthalmitis after MIGS surgeries. 9 cases of endophthalmitis was associated with the eye stent, 3 with the gel stent, and 1 with CyPass. No cases were associated with MIGS that had no implantable device. Endophthalmitis after MIGS may be of similar frequency when compared to cataract surgery alone, but with potentially more virulent organisms. Ultimately, the incision is the biggest risk factor for infection. This study looked at cost effectiveness of trabeculectomy versus the micro shunt in the US Medicare system. Even when the micro shunt device is free, the procedure remains dominated compared with trabeculectomy, which continues for 20 years into the future. There is these modeling things that we can do called willingness to pay threshold. Of $50,000, the microshunt's likelihood of being cost effective is only 6%. Trabeculectomy had higher efficacy and lower cost in 78 of the 1,000 iterations of the Monte Carlo simulation. As you can see, the MIGS procedures are just not cost effective compared to the benefits that they provide. Reporting clinical endpoints. This is from this year's paper. At 2 years, once again, it is shown that cataract surgery alone is giving you 20% or more reduction. The mean number of medication decrease, again, about 1 medication. The recommended minimal clinical effective cumulative probability of surgical success is 65%. Combined cataract and MIGS should provide meaningful reduction than cataract surgery alone. So the surgical success for standalone MIGS, as defined by this paper, is 21 millimeters or less of mercury, along with reduction of 20% or more from baseline, without increasing glaucoma medications, without additional laser, incisional surgery, or loss of light perception. And surgical success for MIGS with cataract is all the above, along with a decrease in medication of 1 from baseline. So that means if you do cataract combined with MIGS and you reduce 1 glaucoma medication, it's considered success. But wait a minute, with cataract surgery alone, you can reduce 1 medication. So what is MIGS adding as a benefit? This paper is literally hot off the press. This is published in April issue of Ophthalmology Glaucoma. 2,770 ophthalmologists were paid $41 million between 2016 and 2021. 273 were glaucoma specialists. Well, that tells you how many glaucoma specialists are adopting this. Only 10%. 390 of this entire cohort were paid $27.7 million. They were called high rollers. These high rollers received payments for consulting and speaking fees and were more likely to be actually glaucoma specialists. This was excluding travel. The odds of high MIGS utilization increased for increasing amounts of payment, indicating that the companies anticipate greater return from their investment in high rollers. Those who received payments from the companies were more likely to perform the higher number of MIGS. So how did I decide to overcome this MIGS addiction? That's what you really need to know. Learn how to do a predictable SLT laser. Now that the IOP is controlled off 1 medication, there is no need for MIGS. Do it 360 degrees, titrate it, correctly identify the TM, don't treat Schwalbe's line or ciliary body, and don't use post-SLT steroids or NSAIDs. Identify intermittent angle closure in time. Intermittent iris touch of the TM worsens glaucoma. Learn to better post-op management of trabeculectomies, intense steroids, steroids for life, release sutures in time, aqueous suppression if there is cystic nature, and learn to evaluate the microcysts on the surface of the bleb. Thank you very much for not shooting the message.